Hello! Welcome to the live stream. I'm gonna have feelings today. As a warning, this is gonna get spicy because we are talking about healthcare. And as much as I feel like I haven't prepared enough for this live stream, I've actually been preparing most of my life by experiencing the American healthcare system. And it's going to be exciting. Thank you all for joining. I see that there are some folks from outside the U.S. in the room. I have a very multicultural donut here. So this is a rhubarb lassi donut. It's not as red as it looks next to everything else. It has coconut flakes on it, rhubarb flavored like milky stuff, and then those are little safflower blooms kind of in it. I don't know. It's got a lot going on. So Rural, thank you. I appreciate the compliments for the hat. I wore this yesterday, and a lot of people said I looked like a vintage air hostess, and I actually originally acquired this outfit for an Emirates air host like costume, but I didn't put the full thing there. Enough about the donut. Tell us about the hat. I just thought it would go with this red jumpsuit, and I went for the red and blue theme since we are talking about American healthcare. But we are also talking about 10 other countries' healthcare, rich countries' healthcare, because this whole live stream today is mostly devoted to digging through the Commonwealth Fund's 2021 Mirror report, which compares U.S. healthcare statistics against 10 other countries, all of which are rich countries with developed economies. And so the countries that it compares against are Australia, Canada, France, Germany, the Netherlands, New Zealand, Norway, Sweden, Switzerland, the UK, and then the US. And the reason that they do this, they actually update it every single year. The update is predominantly based on 2019 data. If people are interested, we can dig through the methodology for the different things. But it is a very fascinating study, and yet again, the United States has ranked last in every single category because America. So it looks at the healthcare system and less the health of people, but it talks about people's interactions with the healthcare system. And I think it's really important when we talk about health care that we recognize that medical care is not at all the same as health. They are related, but actual medical care and access to health care is only about 20% of the total what makes up health. And one of the reasons that the United States' health outcomes are so miserable, so we, compared to all of the other countries in this study, live 5 years less. We have, more adverse effects. We have worse patient outcomes. We rank poorly on all of this accessibility and outcome statistics that we're going to go through today. One of the reasons that the United States does so poorly is actually because we really underinvest in the other social determinants of health. So the things that matter, that truly matter to healthcare, are not just medical care. Some of it is genetics, but about 60% of actual health, not health care, is like social spending. So things like housing, income distribution, those things the United States does really poorly at. And because we do really poorly at them, we have worse health outcomes. But we're looking particularly not just at the health of the United States, we are looking at how inefficient the healthcare system is, because it's kind of mind-boggling how bad America is at healthcare. And I think a lot of Americans don't have experience with other systems, and so we have been fed kind of a line of propaganda that the United States is, yeah, we might be expensive. Sometimes it might be hard to access, but like we actually have better health care. We have better health care than any other country. And I'm not saying that we have been fed that line in order to make Americans sound dumb. There is a lot of money in this business. Services is the majority of the US economy. And it is an important part of marketing for the healthcare system because sickness equals profit in this country. And every country has, it's not like there is an alternative that we could just slap on the United States and it would fix it overnight. I know as much as we can get lost in the policy details of what if we had single payer like Canada, what if we had socialized healthcare like the United Kingdom? What if we just slapped Germany's system on the United States, which was functionally what the Affordable Care Act tried to do? Like, what would happen then? But there is no perfect alternative because there is no clear alternative. Literally every single country does distribution of healthcare differently. And that is one of the reasons that, one, it is challenging to figure out how to improve the health, public health. Something that we all have learned a lot more about what public health is versus individual health in the past and what health care is, right? A lot of us have put off health care and it has negatively impacted our health during the pandemic, but it is impacting public health in a positive way. And that is like, there are just so many complexities to unpack here. And I think the Commonwealth Report is a good way of approaching it. Commonwealth Fund report, which they are a nonprofit kind of think tank that does a lot of health economics research in the United States in order to try to figure out how to have a better and more equitable system here. So it's interesting to talk about like the different ways in which U.S. healthcare is screwing over American consumers and why we really are healthcare consumers more than we are people trying to get healthcare in the system. And I think it's also fascinating to compare where some of these other countries fall on the spectrum. So we are not going to solve American healthcare in the next hour. We are going to take a break for a donut when my steam starts coming out of my ears because I have feelings about this. But I think it is important to actually add data to this conversation because it is a very political issue in the United States. And we'll get into one of the reasons why it is a political issue because it is linked to some other issues that are uniquely American. One of those most notable ones is guns and access to guns. And I know that that sounds like a non-issue when it comes to, you know, making sure that you get an in-network provider for your primary care physician. But in fact, guns are one of the reasons that healthcare costs so much in this country and one of the reasons that we have such poor health outcomes. So, and lower life expectancy. And so we'll talk a little bit about that. And we'll also look into kind of the ways in which these different systems that they looked at differ in these main categories. Rural says, gonna end up paying about $250 for my annual physical because, surprise, the lab is out of network. Ooh, maybe we can talk a little bit about how you might be able to fight that. But that is actually a perfect lead-in to talking about this. Does anybody have any other questions, I guess, before I just dive into rambling about healthcare? There is so much to cover here that this report is very fascinating. They do this every year, so... Joe says, I don't even know where my own country ranks, so this will be interesting. Hopefully you find that Australia is doing a little better than some of the other ones. So let's talk about this. Okay, so this study compiles a bunch of different data sources every year. A couple tweaks to their data sources simply because of lack of availability of one of them. So like some tweaks to their methodology. But here are the areas that they evaluated: access to care, care process, administration efficiency, equity, and healthcare outcomes. So the US, lovely, did a great job. We ranked in the bottom everywhere. Let me pull up the actual thing. Where did I put it? It's in my files. Oh no, now I'm never gonna find it again. There we go. Cool. All right. So we are gonna pull up the healthcare system rankings here that came from the Commonwealth report. Overall, the United States ranked 11th in the overall ranking. So you can see that Australia ranked number 3 out of the 11 countries studied. So there you go, Joe. When comparing access to care, care process, administration efficiency, equity, and healthcare outcomes, and Australia actually had the best equity in their healthcare systems. This is maybe a little bit prettier version of this. Notice just quite how far down there the United States is. Dead last is the best description of this. And, when we're looking at comparative healthcare performance scores, they're putting everything together. The 4 features that really distinguish the high-performing countries from the United States is that they provide for universal coverage and remove cost barriers. They invest in primary care systems, ensuring that high-value services are equitably available in all communities to all people. They reduce administrative burdens that divert time, efforts, and spending from health improvement efforts. So that is a perfect example. We want people to go get primary care. However, at the same time, if they are worried about the fact that their, diagnostic lab is sent out of network, and that it's going to cost them $250 to go get a routine checkup, then guess what happens? Then we have made a administrative burden. The most notable thing for me about this is that they found that lower income people in other countries, in all of the other countries other than the United States that were included in this, lower income people had easier time accessing to care and less barriers to care than high income people. And that's because the United States has made a choice. We have made a choice around the philosophy of how we deliver healthcare, which is that it is better to deliver head transplants to the few than it is to make sure that everyone has access to the same basic preventative services. So we have that. What is really floors us is that the United States does have, in many regards, the best health things. We have the best things, so to say. So we have leading world clinicians. We have some of the best trained and highest performing clinicians as far as depth of knowledge and leading in research. We have great data. We have the best buildings. We have the best technology. But we are still 5 to 10 years behind all of these other rich countries in healthcare outcomes, and we live 5 years less. And there are a couple things there. One, we are unwilling to talk about guns because a large proportion of the suicides and our reduced health expectancy in the United States is because a lot of people die by suicide. And one of the reasons that dying by suicide is such a large component, in addition to access to mental health services, is the open availability of guns in the US. And then additionally, we are very bad at having people seek preventative care. So we get to the point where we are spending a lot of money on life-saving measures for people who are likely not going to live, driving up the cost of care using this high technology for something that if it was caught early, it would have been able to be treated with better things that cost less, that have a higher degree of outcome in the United States, because but people put off seeking care. They put off getting preventative care because they are so afraid of a bill. You have like you're like, I'm feeling kind of weird, but like, it's probably not a big deal. I didn't drop down on the floor, so I'm going to put it off because who knows how much it's going to be if I go to the doctor. Maybe they actually run something as a diagnostic test instead of a preventative test, and it might cost me $10,000, right? So it's, like, quite frustrating. Additionally, like, one of the big things is lack of price transparency in the United States. Like, that is the thing that we now are like going and moaning on about, that it's going to improve things, because one of the reasons we spend so much is because there is very little price transparency as a consumer. But one of the reasons that healthcare is so poor healthcare outcomes are so poor in the United States, despite spending more than every other country, that is the only thing we lead on, is that we spend more money, is that we are not rational consumers when we come to healthcare. We have this belief that the free market is going to solve things, but the free market can't solve something, because it's not like when you're choosing between 4 loaves of bread and you can see the price of all the loaves of bread, and if they're too expensive, you can just not buy bread. Because guess what? You aren't a rational consumer when it comes to healthcare. If your kid has a seizure out of nowhere, you are going to, barge into that emergency room and say, I need tests run on my kid. What is happening to my kid? Right? So you're not a rational consumer when it comes to healthcare, and there's not transparency. We do have people that are in an ambulance and are calling or Googling to see if a hospital they're being taken to is in network in the United States. And like, that is a lack of cost transparency. So this is healthcare spending as a percentage of GDP. I think this is very notable because it is the only place the United States leads. And this is one of those expressions of people putting off care. We don't necessarily get more anything. So like, we don't actually get more hospitalization. We don't get more bed days. We don't get more doctor's visits. We just pay a lot more for these things. We pay more for medications, but we don't take more medications. We also, we pay a lot more for administrative costs and specialist doctors. So doctors in the US, especially specialists and surgeons, get paid a lot more than other rich countries. And that is something that any doctor who's worked abroad who then comes into the US will tell you that is true. And they are paid based on performing procedures, seeing patients. So they don't get as much time. They don't get as much ability to evaluate people for conditions. So one of the things that we get slightly more of than a lot of other countries is diagnostic tests. And diagnostic tests can cost wildly different things. This is where that price transparency comes in. A vitamin C test might be $8 at one lab and $800 at another lab. So we have no price transparency about that. And there is a lot of administrative costs built into that. So that is one of the big things. We don't get super fancy diagnostic tests compared to other countries, just get slightly more. But we're still behind Germany and Japan as far as both the fanciness of the diagnostics that we get and the frequency of diagnostic tests. Scott says, how many of these countries have outlawed advertising medication? Oh, that's very interesting. God, remember when you couldn't advertise medication on television? How different the commercials were. I remember. They were allowed to start doing it when I was a kid. I don't know the answer to that, but I would love to know the answer to that, and I will be interested in that. Joe says, I've spent some time on international support groups for my pregnancy condition, and it's bleak. It all matches what you're describing. Yeah, I mean, that's the thing that is terrifying about that's the thing that is terrifying, is when people talk about accessing healthcare in the United States, people from other rich countries are like, what what is this hellscape you're describing? Yet we're so convinced that we have access to the best things that combined with a bunch of other political reasons has made it really, really challenging. But like, I don't think that we could, if a magical wand was waved and Congress could implement like a socialized healthcare system like the NHS tomorrow in the United States. NHS is the UK's health system, if you do not know. I don't know if we have any UK people here because it's 1 a.m. in the UK, so hopefully you're asleep. But I think what is particularly important to understand is that, like, if we were to just place it in the United States, it would become the biggest pork barrel thing that you could possibly imagine. Lobbyists would be lining up in Congress to get these socialized healthcare contracts, as we already see in our few socialized medical programs, which are VA, which is more operated by the government. But, you know, that would be under the current systems in the United States, I don't think that we could lock, stop, and barrel implement something like socialized healthcare. Joe says, we have ads for over-the-counter medications like paracetamol. Yeah, that was like what we had before. But also, what is considered over-the-counter versus under-the-counter in different countries isn't always the same. So, like, one thing I was really surprised about, so one, you're not supposed to be able to, like, you shouldn't get paracetamol from the NHS. You should, like, or on the NHS, you should just get it yourself at the store because it is over-the-counter. But a lot of people will get it through the NHS, but it costs both you and the NHS more if you get it through the NHS than you just get it through the drugstore. That's like generally fun fact. But also I was very surprised, like melatonin is over the counter here. But in the UK, you have to actually go to a doctor. It's under the counter there. I found that very... Joe says the USA should be the leader in treating it because they have such excellent research and protocols, but access to that is impossible. Admin, poor doctors, insurance, and work get in the way. I mean, that's like a huge factor. And then also, additionally, as you mentioned, work from the very specific, there's 2 ways in which I think the way that Americans work influences a bunch of things. 1, we don't have paid sick time in the United States. And 2, 50% of Americans get their healthcare via their employer. And one of the doctors who wrote the book that I called American Sickness, that I think is phenomenal, she describes employer-based healthcare as the original sin because it originally happened during World War II, when we had a wage cap in the United States in order to try to curb inflation, and unemployment was at 2% in the United States, which is extremely low. It's lower than you want. That's lower than like frictional unemployment. And in order to compete, you know, we were seeing like rampant inflation because employers were getting all these government contracts. There was a bunch of spending. We were printing money, and they were, raising wages in order to compete for mostly factory workers in order to like make things like munitions. And when the wage cap was implemented in the United States during World War II, then employers started doing fringe benefits in order to attract workers. And initially, this employer-based insurance wasn't this like huge overblown system like we had implemented here in the United States now. It was sort of meant to be like, oh, like a fun bonus perk, like now that you get like goat yoga at your workplace or something like that. It was like, oh, this is like an extra thing, you know, we'll take care of some of the healthcare costs for your family. But there was also far less advances in healthcare at the time. So that is part of it, is workplace-based employment, because this leads to the fact that the entire system is sold as a benefit and perk, and the consumer has 2 big issues. 1, they have to stay with their employer in order to access the basics of healthcare. And Two, they are insulated from the price of care and the risk of care. So we have no idea how much things cost because we've got this 3 layers in between, right? You got your employer possibly paying for a portion of your premium. Your employer is shopping to figure out what healthcare plan you're offered. So, like, this is one of the big problems a lot of people had before the ACA marketplace, which is like, if you work for an employer that's based in a different state, there might not be any providers in your state that are in network because they are shopping for insurance in a different state. And so you've like got this additional layer. And then additionally, the insurance is doing the negotiation with hospitals and doctors and the billing and everything. And the big problem is that we've got insurance and hospitals both competing for profit and arguing with each other and driving up each other's costs. So and then the second part of work, I'm getting off track here, but the second part of work that's really important is the United States has very, very, very poor workplace rules around medical leave, parental leave. So in the United States, we have no guaranteed sick days off work. We have no guaranteed paid parental leave. If you work for an employer that has over 50 employees at one location, then you do qualify for the FMLA, which is unpaid leave of up to 6 months. So you have to save up and you're allowed to keep your health insurance. And that is it. Some employers do offer some form of paid health insurance or paid parental leave, but usually only for the birth parent. And then additionally, sick days. So sick days in the United States, this is the first time I've had them. And that is probably because my state implemented a requirement that employers over 5 employers offer them. So FMLA you can also use for both parental leave, but you can also use it for disability or including someone in your family gets sick. But once again, that only guarantees that your job is held safe. And you can use it incrementally, so it can give you some sort of accommodations if you need more time off for doctor's appointments or something like that. John says, sometimes the best things include tech for denying care in the U.S. Long form piece on AI systems that's making the opiate epidemic worse in Wired this week. I am totally going to read that. I just read a long form piece in Wired that got me into a weird hole this week. I swear, I'll get back on track here. But there was a very good long form piece about Bera, who is a Georgian pop star whose dad was former prime minister of Georgia and a billionaire in Georgia, and his son Bera is an albino like rap pop star in Georgia. Anyway, the Wired piece was out of control. Interesting. I thought FMLA was only 12 weeks. Wait, it's 24. It's up to 24. Wait, someone look up FMLA and make sure that I'm not getting that wrong, but I thought it was 24. I've never worked, in my entire life, I've never worked at a single employer that's big enough to qualify for FMLA. And 50% of Americans do not work at an employer that qualifies for FMLA. Cheryl says, so publicly funded healthcare in the U.S. VA, military standard of care is not the same as if you were in the public sector. If I was not in the military when I was pregnant, I would have had ultrasounds, etc. Yeah, right. Well, you would have if you had employer-based care, but you may or may not have unless you worked for the military. But yes, VA care is very fascinating. VA reimbursement rates, wait time, standard of care, it's all very fascinating. And the VA is exempted in a lot of ways from the ACA, standard of care, things like that, because it exists in a different place. And it is also, we'll come back to the VA. But I think the important thing to note is that only, I think, 3.8% of Americans have in any way access to the VA. So while it is important to study it as what it is, which is it is the only example of truly publicly funded socialized healthcare in the United States, it is it does not affect most Americans, and only that's 3.8 that have access to it at any point. And that includes people that probably do have private sector insurance because they are former military and, work in the private sector now. Okay, Rural says it is 12 weeks. I don't know why I upgraded it to 24. What is 24? Okay, 12 weeks. There we go. So 3 months, 4 months. Do I know how to do math? 3 months. I have an economics degree. I know how to divide things. Wow. It's notable that I upgraded that in my head because I have definitely covered it a lot. Okay, so healthcare spending as a percentage of GDP. As mentioned, did my AirPlay decide to turn off? It did. Okay. We are back, right? Okay, cool. Now, this is healthcare system performance compared to spending. As you may have noticed, we ranked last on healthcare performance and first on spending in the United States. It's pretty interesting to see this on a plot chart, isn't it? Real depressing. When I said dead last, I was not exaggerating. Tomas says, just found out recently that my employer grants 6 weeks paternity leave. Not that I'll ever use it, but not that your employer should have to grant it. I mean, this is where my bias is coming out, but I think parental leave should be a thing that is required. It shouldn't be a thing that is generously bestowed on you. Oh, the other thing about FMLA is that you have to work for that employer that has over 50 employees at one site. Additionally, you have to work for them for over a year. So what happens is a lot of people, they can't change jobs, essentially, when they're pregnant because they then will not qualify. And you also have a requirement to disclose your pregnancy, as long as you know, within a certain period in order to use FMLA as parental leave. Okay, so this is where the ranking, as you can see, most of them are pretty nicely, together. One notable thing, one reason that a lot of these countries outperform the US when it comes to healthcare outcomes, which is not the same as healthcare efficiency, it's not the same as healthcare access or equity, but healthcare outcomes, is because they invest in social services, especially for children and working age adults. And as much as we can pretend that childcare is a separate issue, we can't pretend that childcare and parental leave are a separate issue when the majority of Americans access their health insurance through their employer. Okay, so healthcare systems performance scores affordability. The United States is last, as you may expect, given that we, experience this. Let's look at this actual report here. So what were the notable differences in affordability? So one of the big things here was price transparency. Sorry, I'm scrolling a lot. I'm trying to find it. Okay. So, the big thing here with affordability in the United States was lack of transparency. We also have 12 states that still have not expanded Medicaid, despite continually trying to sweeten the pot. But one of the reasons they're trying to sweeten the pot is saying that it will add money to the state economy. Once again, affordability and access are not the same. The U.S. has the poorest performance on the affordability subdomain, scoring even lower than the next lowest country, Switzerland. Compared to residents of the U.S., residents of the Netherlands, UK, Norway, and Germany are much less likely to report that their insurance denied payment of a claim or paid less than expected. So the Netherlands, if you are not familiar with the way that they do insurance there, insurance is mandatory and universal, which is an extremely important part of affordability of care. But they essentially don't get to compete on what it covers. So they compete on performance. All of the insurances pretty much have to cover the same thing. You get it on the private market, but it is not regulated. The type of competition is not the same as the competition in the United States, which is a flawed market, right? Because one, as we've discussed, you're not even the one choosing if you're like half of Americans and get it through your employer. You're choosing from an extremely limited set of options for which you don't necessarily have transparency about whether or not things are in here. They are, and residents of the top performing countries are less likely to report that they had difficulty in paying medical bills. And this is like a huge issue when it comes to this. Like, that is one of the like biggest arguments against this, is that the affordability was so bad even among high and low income people. So if we go back to this other file, which I have lost now. Switching between two things on the iPad during a live stream is not that efficient. Okay. So when we look at lower cost-related problems, access problems to low-income populations, you look at higher income, which is median income and above, still had cost-related access problems. And it affected more people in the United States in high income than it did in low and high income in all of the other countries. So it is, I mean, I feel like this speaks for itself. I don't know what we need to dive into here. The UK ranks the best on affordability. They actually do extremely well on patient outcomes. They have socialized healthcare. You will note that and they actually do pretty well on specialized services, including low wait times and access to care. Unlike Canada does, like, one of the issues with Canada's, services is that we do see that, people will go private in order to access specialized care if they are higher income, which is, Canada is a single payer system. It's not socialized. And then additionally, drugs are not included in it. So there are, Canada's system, 95% of Canada would prefer to have their system, I think was the latest polling, over any other country system, but they do admit there's problems there as far as equity. So let's go back to this affordability matrix. I mean, that's it. That's all we really need to talk about with that. All right, let's come to equity. So equity is looked at income-related disparities. So they had standardized data, so data that was available across all the countries. And the standardized data for the other metrics was a lot easier, but equity was a little harder just because of the different racial and ethnic makeups in each country. Australia, Germany, and Switzerland rank highest on the equity domain, meaning they had the smallest income-related disparities in performance based on the included measures. So in the US, had the largest disparities between income groups, except for those measures related to preventative services and safety of care. So safety of care is like making sure that there's cross checks to make sure that medications don't interact with each other when you get prescribed things at the pharmacy. Safety of care is, making sure that G-tube lines get changed or something like that. Like safety of care is the kinds of routine checks in the system that make sure that that medical care is actually safe. And then measures related to preventative services. So this doesn't mean that the US was better at preventative services, but we largely, due to the Affordable Care Act, which was how we tried to fix things, we fixed some things. One of the things is that the US tried to kind of copy the German system and say, okay, there is this pool of basic preventative services that all plans that are approved for this have to have. Cheryl says, imagine if Obama pushed through socialized healthcare when he had both houses. Where would we be now? I don't know. It's hard to imagine. That was also so long ago. And so, potentially we could have maybe figured it out. But given how poorly so much of the Affordable Care Act rollout went poorly, maybe not well. So this is where equity ranks. I don't know. Do we want to dive further into this data? Is this data interesting to people? because we can dive further into the actual equity ranking. So about 10% of adults in the United States reported experiencing medical or medication mistakes in their care. Pretty much no one did a great job at talking between like in-home health aides, insurance, hospitals, all of those systems, like the actual like coordination between administration and local like care and emergency care communication. No one really stood out. Nobody did miserably except the United States, but no one really stood out. But the measures of primary care doctors and specialists, the countries that performed particularly well were Switzerland, New Zealand, Australia, Norway, and France. So the US and Germany achieved the highest performance on engagement and patient preferences subdomain, although the US has the lowest rate of continuity with the same doctor. One of the reasons that people think that the United States has a low rate of continuity with doctors is that the average American changes jobs every 2 years. If you're changing jobs every 2 years, you're likely changing insurance every 2 years. And because of that, continuity can be really hard. In addition, even if you have the same insurance, if your doctor switches whether or not they're in or out of network, you may change providers. And affordability access is one of the big reasons that we don't have as much. Among people with chronic illnesses, U.S. adults are the most likely to discuss goals, priorities, and treatment options with their provider, though less likely to receive much support from health professionals as they felt was needed. So one of the big issues with chronic care patients in the U.S. is that they all report a greater administrative burden and a greater burden of having their doctors actually understand how to appropriately bill and make sure that they can afford access to services. And I see this as someone who does have a chronic illness and is on an extremely expensive medication in the United States. I regularly have to advocate to say, I can't afford that. You need to bill it at this in order for it to be diagnostic. And I am an extremely sophisticated healthcare consumer. Tomas said, Obamacare literally saved my life when I had a bad dental infection that started to make me sick. Almost ended up in the hospital. Oh, wait, that was the Oregon Health Plan. I mean, that was thanks to Obamacare that you qualified for the Oregon Health Plan. So Oregon Health Plan is Medicaid, which is our low-income health plan that is administered by the states. And one of the reasons why we struggle so much in the United States is that even with the sole exception of, I would say, maybe VA, which is more centralized and socialized than the rest of it. Even when it comes to the Affordable Care Act standardization, Medicaid expansion, which is our low-income healthcare, and Medicare, which is for people over the age of 65 in the United States, the big problem is that every state implements it in a different way. So that, like, what access to providers looks like, whether or not you have access to any in-network like providers anywhere in your state, any of that is very challenging. So, any other questions here? So the U.S. high performance on preventative care subdomain is based on their rates of mammographic screening and influenza vaccination, as well as the percentage of adults who talk to their doctors about nutrition, smoking, and alcohol use. Remember how I mentioned that in addition to social spending on things like housing, schools, education, influencing health, another thing that influences health are all of these lifestyle factors that people don't necessarily get the opportunity to discuss with their provider. And the U.S. does a better job of that, largely because of standardizations in Obamacare around that. But like we said, it largely differs. All right, let's talk about administrative efficiency. So this is how well healthcare systems actually do at reducing documentation and other bureaucratic paperwork. I tracked how much time I spent on the phone in 2020. And in 1 year, I spent 38 hours on the phone just dealing with trying to get my medication covered and delivered by my insurance. I had the same insurance all year. I'd had the same insurance for years. That is how much time me, as a patient who is otherwise extremely healthy, just to get one medication. Imagine if my first language wasn't English, if I didn't speak English at all. Imagine if I had other comorbidities. Imagine if I was not college educated on economics and, able to spend all of my time like digging through the formulary in order to figure out what tier my medication is and then know how to argue with all of the places. Imagine if I didn't have a job where I could take a break and then be on the phone. Like I spent 38 hours. So, administrative efficiency. The top performers on administrative efficiency domain are Norway, Australia, New Zealand, and the UK. Let's look at that. So, that is affordable deaths. Let's go to efficiency. Where did it go? Oh. We don't have a graph for efficiency. I thought we did, but we do not. Okay, so the big issue is when patients, so this data was compiled compared to provider surveys and patient surveys, and US doctors are the most likely to have trouble actually getting their patients medication or treatment because of restrictions in insurance. And this is a great, like, I can illustrate this myself with my $7,800 a month medication, which, just to note, costs a lot less in other countries and also has a generic approved in other countries because they keep getting their patent extended in the US. So they have a 39-year patent in the US, but they have a biosimilar or generic approved in every other country in the world. And when I got on this medication 5 years ago, it was $800 a month billed to my insurer. Now it is $7,800 a month. So that really shows you how much they've inflated the cost of the medication, especially once other markets started switching to the biosimilar. So the NHS switched to the biosimilar available of my drug, and in one single year, the NHS saved £378 million just by switching to the biosimilar of one drug, which isn't even used by a huge proportion of patients. And that really tells you something about how much this, like, the pharmaceutical cost and inefficiency and inability to negotiate and extended patent lengths and all of that kind of wraps up into this overall cost. So top performers are on the administrative efficiency domain are Norway, Australia, New Zealand, and the UK. And the US ranks last. The UK doctors are more likely to have trouble, US doctors are more likely to have trouble getting their patients medication. Compared to most other countries, a larger percentage of the US say they spend a ton of time on paperwork related to medical bills. For non-emergency care in the US and Canada, they're more likely to visit the emergency department, a less efficient option than seeing a regular doctor. And a lot of Americans see the emergency department because they don't have insurance, but they know that as far as critical care, they can visit the emergency department and get access to care if they need life-saving care. And part of this has to do with the lack of provider knowledge. When it's incredibly hard to find and figure out if a doctor is covered by your health insurance here in the United States, then it can be really hard to have a relationship with a primary care doctor and know to go to a primary care doctor. So, in the UK, like, everything runs through your GP. And if you're in the US, if you're on a PPO, then everything runs through your primary care doctor. But often that primary care doctor is assigned by the PPO and you may never interact with them. Tomas says, so it's literally cheaper to pay someone to fly to the UK to pick up your drug than to get it through US insurance. Well, I can't pick it up in the UK because I'm not covered by the NHS. So you have to live there, be a resident and be covered by the NHS. Annoyingly, if you're an immigrant, you have to pay $300 a month, even though you're also paying through your taxes, or $300 a year. Sorry, $300. That was my American coming in. 300 pounds a year is what you have to pay, roughly. If you're an immigrant and you are not a UK citizen, because they just can do that. But I could fly to Mexico. So I calculated what my insurance would save, and this is a perfect example of how like the sickness equals profit here in the United States, and we have these rampantly inflated costs. But I calculated what my insurance would save just on me alone as a patient, if they were to fly me every single month to Mexico, put me up in a 4-star hotel, and have me just go get my drugs from a random Mexican pharmacy. I can look up the prices online because they have price transparency in Mexico. And it would cost the insurance $50,000 less a year just on me as a patient. If they flew me, put me up in a 4-star hotel once a month, had me get my drugs from a Mexican pharmacy, and then also paid for me to like go have a nice per diem, like a nice lunch out, dinner out. That's how much they would save. They would save $50,000 a year on me. And that is because of how inflated the cost has been. And that's just the cost of the drug. There are so many other costs involved with my drug that are unnecessary. So I get overnight FedEx delivery. I have 3 middlemen involved in getting my drug. This is not a controlled substance, by the way. It's just very expensive. So insurance has made it extremely complicated to get. I have a pharmacy benefit manager that all they do is call me on the phone to then send in the order to the pharmacy, who then sends the order on to FedEx to overnight it, deliver it to me. It's refrigerated, so it's overnight refrigerated delivery. It's just so inefficient. And I'm not allowed to choose a pharmacy benefit manager, and I hate them and they're annoying, but yeah. So should we eat a donut? Do we have any questions about these? The Lilly TripAdvisor drug plan. I'm trying to convince them. I'm waging a trying to convince them campaign. I've recorded a lot of phone calls. We're a one-party state. And I am trying very hard to convince my insurance that they should do this because I think it would make good content. And it would save them money. Win-win. My drug is about $40 in India. So, yeah. And that's not even the biosimilar. That's like the brand name is about $40 a month versus $700, $800 a month. It's out of control. OMD TripAdvisor. I love it. Should we eat a donut? Woo! Okay, this is the donut. It's a rhubarb lassi. Perfect segue from how much my drug costs in India. Yeah, and it's got coconut flakes and then safflower blooms, which I didn't even know you could eat. It is very hard on the top because it's been sitting out in like a hot apartment all day. It's just a fluffy regular donut. So the only thing that's flavored is on the top. I don't know why they decorated only one side. I'm confused about that. I looked online and it wasn't like it was just my donut. It smells very coconutty as I get closer to the coconut. I'm not really getting rhubarb from it though. I feel like this donut is a little bit like American healthcare. It's very pretty, but kind of disappointing on the inside. Is our cat cam moving? Oh, the cat overheated, so she abandoned the cat cam. Anyone have any donut questions? Let's go to cat cam. I'll just eat this donut quietly. Dora's very tired. She's flat because it's too hot. It was like 40 degrees Celsius here, 100 degrees Fahrenheit earlier. It might have only gotten to 99. I think it was 100 though. It's too many degrees. Is the real answer. This donut is like fine, but it's like a 3 out of 5. I don't know. Not a high rating. But Dora's very tired. It might even be a 2 out of 5. I need to be able to do half donuts. Tomas says, can you research dental implants for me? I can't get a dollar figure out of anyone so I can budget the work. Oh, do you want to go abroad? Because you'll save a lot more going out of the US. We're not even going to get into dental because that's a different situation. Even though it is an important part of healthcare. Yeah. Iris says 2 out of 5 because of the lack of rhubarb. I mean, I guess the top had rhubarb in it, but it didn't. I guess I kind of was hoping that it was more like a fritter and there was like rhubarb inside of it. Tomas says maybe. Because I think the big problem with dental implants in the United States is like there's like no dental insurance that's really going to help you cover it because the costs are so high and most of them have like very low out-of-pocket maximums, like $1,000 or $2,000 a year. So Cheryl says, don't go to the UK. So, fun fact, Americans like to make fun of the United Kingdom's teeth, but they actually have the lowest cavities of any country on Earth. And they have some of the best preventative care. They just don't have the best, they don't have as much emphasis as aesthetics put on as the United States, which seems to think that straight teeth are fine, even if they actually have a lot of cavities. So, Tomas says need at least 5. Yeah, my recommendation would be dental tourism. The Mexico isn't heavy for dental tourism, although some people do it. It's more common for medical tourism. Dentures from Mexico are actually decent, not the same as implants. I think dentures are fine. I've heard not to get veneers from Mexico and not to get implants from Mexico. Dental tourism isn't as big in Mexico. Vietnam and Thailand both have excellent dental tourism. So if you are willing to venture over there, you can get great low-cost dental tourism. The cat just like sneezed, coughed herself awake. So, oh, bath time now. Rhubarb strawberry would be a great donut. I think they actually had that fritter a couple months ago. I'll have to dig through past live streams. I can't remember. Their fritters are always great. I think I actually have learned that there's 2 kinds of donuts that I prefer from this experiment of eating donuts on the internet for a year and a half. Is that I really like old-fashioned donuts, which are not a thing I would have thought that I really like. But I really like old-fashioned donuts, and I really like fritters. More than I like just a regular raised donut. All right. So, should we dig into... Okay. Should we dig into spending? So, we don't need a mirror for this. There is a kitten now being held like a baby behind there. Is there a wiki for OMD topics/donuts? Oh, gosh, we need to make one. Why have we not had a master list just going on the forums at the very... That's dumb. I'll fix that. There is like a donut list, but I keep it personally. I haven't put it on the internet for no reason I haven't figured out. So I will do that. I will do my best to do that. Okay, so healthcare outcomes. Most countries have achieved better healthcare outcomes than the United States. On this group, Australia, Norway, and Switzerland rank at the top of the 11 nation group as far as their healthcare outcomes. That is Norway, which has the lowest infant mortality rate, 2 deaths per 1,000 live births, while Australia has the highest life expectancy after age 60, which is 25.6 additional years of life expectancy. So for those who survive to age 60. The reason we do life expectancy till age 60 is, or after age 60, is that life expectancy tends to be very much altered by your infant mortality rate. So you take that out and you get a better metric, really. So the US ranks last overall on healthcare outcomes domain. Of 9 of the 10 component measures, US performance is lowest among the countries having the highest infant mortality rate, 5.7 deaths per 1,000 lives birth, and lowest life expectancy at 61 years. We have a 5.6 years lower than Australia, the highest ranked group at life expectancy. And the US rate of preventable mortality is more than double the best performing country. So 177 deaths per 100K population versus Switzerland, 83 deaths per 1,000. So let's look at this in a actual diagram. Wait, mirror, mirror. Doo-doo-doo. I keep calling it mirror, mirror because that's what I have to title. So look at the differences on this screen. Do I need to mirror again? Okay. Look at the differences on this screen. So this shows you a range. The top one is 2009, and then 2019 is the other one, whatever the most recent data is. So the US is avoidable deaths and 10-year reduction in avoidable mortality is we essentially got worse. And look at how much better Switzerland did in avoidable mortality and 10-year reduction. That's it. Anything else? Australia's numbers were from 2008 and 2018, as opposed to the other numbers. So, administration efficiency, equity, access to care, healthcare outcomes, and care process. Do we have any other additional questions? We didn't really dive too much into care process, but I guess we could. And like what that actually means. That's mostly care process has to do with like if the country is making sure that providers have enough time with the patients, if they're making sure that they talk to them about lifestyle factors, if patients feel like there are barriers in accessing care. So this is kind of the healthcare system performance compared to spending. You will see how efficient Australia is compared to the United States. One of the reasons that Australia and Germany probably have such good efficiency related to spending is that they have less options, fewer options in their like total healthcare program. So the United States has a lot of options and competing interest when it comes to it, but there is a lot more restrictions on what can and cannot be charged within the single payer or the limited payer systems in both Australia and Germany. Which systems have single payer? So all of these systems are regulated in a way that the United States is not, as far as patient costs, as far as what has to be covered. This is what the Affordable Care Act tried to do and didn't quite figure out. So, how do we feel about the US? Is it a dumpster fire? Because it is. We spend so much money. We spend so much money for so little. Am I still screen sharing? I'm not, right? No. Cool. That's good. I don't want to be. So yeah, we spend 12.5% of our gross domestic product on healthcare in the United States. And we do a terrible job of actually providing health to our citizens. And the big issues are that we do not remove cost barriers, we do not provide universal coverage, and we don't invest in the primary systems that high values and make sure that high value services are available across all people in the country. And we do not invest in reducing administrative burdens. In fact, we profit off of increasing administrative burdens. So we do a lot of time to invest in exactly the things that make everything more complicated and expensive. I told you about the 2 layers of administration just between my prescriber and me getting my drugs in my hand. So a doctor prescribes the drug. Then it has to get pre-authorized for me to actually be on it by my insurance program. So they have to send over all my medical records to my insurer, and they have to tell my insurer, yes, she has tried everything cheaper, because they legally they can do this thing called step therapy where the insurance can force you to try everything cheaper. Yes, she's tried everything cheaper. This is effective. She's been stable on it. Then the insurance has a board of doctors. One of them spends 5 seconds looking at my medical file, decides if they're going to deny it or not, usually using something that tries to figure out any way they can possibly deny this patient from being on there, then send it back to the doctor. Then the doctor sends it over to a different part of the insurance to say, yes, we want this covered. Then the insurance says, hello, you as a patient need to sign up with this third-party pharmacy benefit manager, which is the only pharmacy benefit manager that we allow to cover your medication. Additionally, because my medication is so expensive, I have to re-enroll every single year for my copay assistance program, which is provided by the pharmacy manufacturer of my drug, which is Amgen. And Amgen runs a copay assistance program in order to further insulate patients from the cost of the drug, driving up the cost of the drug because insurance will have to pay. And they pay on my behalf my copay, which sounds really great. Sounds theoretically really great. Except then I have another administrative burden in accessing my drug. I have to sign up for this program every year. I have to swear 6 ways to Sunday that I'm not getting any publicly funded healthcare, so I do not qualify for it if I'm on Medicaid, Medicare, or VA benefits. I only qualify for it if I'm on private insurance, because otherwise I wouldn't be allowed, because it is double charging the government, because they completely write off the amount they pay on my behalf in order to prop up their prices in a consumer market. Now that I've gotten everything, I've got my Enbrel copay card, I've got my insurance card, my insurance has approved my doctor prescribing this drug that I've been successfully on for 6 years. Now, with this information in hand, I call up the pharmacy benefit manager that has been assigned to me. This is a group of people that all they do is answer the phone to send in orders, but I have to go through them. Then they send it off to the specialty pharmacy, who bills through them to my insurance, that then they tack on a fee on top of that. And then that specialty pharmacy sends it off to FedEx. FedEx overnight also takes a cut of it and sends it to my house. So, yeah. If we want to talk about administrative burdens and how challenging it is to access care, I feel like that is a perfect example. There's just so many middlemen that make money off this. The question is not why we live here. It's why do we not advocate louder for change? I think that is the, really frustrating thing. I think one thing that you can do that maybe feels a little less challenging than trying to overhaul the entire healthcare system, because I think what's really, really clear from both this report and from being involved in the healthcare process in the United States is that you become aware that there's so many ways in which it's complicated and expensive and hard to access that there isn't just one solution. Like it would need a bunch of broad policy changes in the way that we access care, changes in the way that people are able to actually get access to, physicians, making sure that like doctors are in the right places and access and availability. Like one thing that you can do that might feel a little less futile is become a better informed consumer. So one of the ways that you can do that is making sure that you're getting itemized receipts. Two, I hate to say this, but try to never get in an ambulance if you possibly can, just because it will cost you money, but it is almost never in network. If you want to learn more about ambulances in the United States, I highly recommend watching the Emergency Medical Services episode of John Oliver's show Last Week Tonight. You can find the full episode on YouTube. He does a great job of being kind of funny, but kind of depressing and breaking down what's wrong with America mostly. And he just did an episode on emergency medical services. I can't even really dive into why ambulances are so expensive, but if at all possible, try not to take an ambulance in the United States, just from a personal perspective. And then the other thing is really understand what kind of insurance you're getting and think about yourself as a consumer of healthcare, because if you're someone that knows that you're likely to need a like hip or knee replacement, or you're someone that's on a lot of expensive medications, you really do want to think about maybe you do want to go for a higher premium plan and lower deductible plan or something like that. Seriously, shout out to John Oliver. I wish I had any of the skill and resources that he had in order to do what he's doing. He's phenomenal. Scott says, I can't comparison shop Medivacs. No, you cannot. You not only can't comparison shop, there's almost no chance that an ambulance provider is going to be in network. So that's great. Iris says, I've never spent less than $500 on an ambulance. And if you happen to have 2 patients on one ride, they double your bill. Great to know. That's wonderful. If you want to learn about a particularly frustrating part of the United States health insurance system, you should learn about something called the birthday rule. So Kaiser Health News does this great segment with NPR every month called Bill of the Month, where they break down a hospital bill of the month. And the birthday rule is a thing that insurance is made up that influences which insurance gets a new baby. So if there are 2 parents, the example was these 2 parents where one of them had good insurance, the other did not have good insurance, and they thought that they were going to be able to choose to put their new baby when it was born on the good insurance. But due to something called the birthday rule, they were not able to put the kid on the good insurance. They did not get a choice in the matter. And yeah. Cheryl says, we recently learned to shop for emergency veterinary services. Another area where price transparency would be really great. At least you can try. Cheryl said, someone I know tried to get a better drug for RA, and even with the help of the drug manufacturer, could not swing the better drug. Like, I mean, that's what's really the frustrating part is, like, even with the copay assistance, you really have to know to navigate within the system. Like, for me, I'm able to be on a high deductible plan with the copay assistance, but that's only if I don't have anything bad happen to me in the first 3 months of every year. And every year I have this clock racing where I'm like, okay, don't get hurt because you haven't met your deductible yet with your copay assistance. You feel under pressure to do whatever for your pets, but take a beat and call around for pricings, x-rays, and ultrasounds. Or if inoculation, is that how you pronounce it? Inoculation? No, inoculation is vaccine. Inoculation. I don't know how to pronounce it, but It's when you have a one-eyed cat. Or dog. It's when you get an eye removed. Yes, your eye was the most expensive medical care after mine last year, Dora. But she's so cute. It makes up for it, right? We didn't really have an option. There was really only one place to go. But anybody have any questions? Anybody just want to rant about annoying things? Iris says everything is fine. Yeah, I've never spent I've never seen anyone spend only $500 on an ambulance, to be fair. I've had my I've called Ubers and taxis for so many people because they don't want ambulances. It's like, no. Iris says, I found a very good vet and will gladly drive the 30 minutes away for it. They literally took x-rays at no charge when my older cat was sick. So lucky. Oh, that's so good. Imagine if doctors did that. Human doctors in America. We're just going to go back to cat cam. I wonder if the mic is picking this up at all. It's probably too directional. Where are we at? Oh yeah, we've been at this for a while, huh? Also, I was gesticulating so much that my watch decided that I was cycling. Iris says, it's been more than 5 years since an ambulance ride, so I might be underestimating lol. Yeah, I've definitely seen people with $3,000+ ambulance rides. Scott Morgan, I'll be listening to It Could Happen Here by Robert Evans about the collapse of America and try not to scream the whole time. I like Cheryl's note about let's all just try to advocate for change here in the United States. I love the cat cam, by the way. I love that I'm just reading the comments over the cat cam. Tomas says, 2019 mountain bike crash. 2 x-rays, 4 stitches, some Bactine, and a handful of Band-Aids in the ER. $2,000 even with good insurance. Oof. So total itemized costs to insurance. This wrist, this was $28,000. And then this wrist, both of which were just breaks, but then surgery to repair them. Because if you're young, they pretty much don't just give you a cast when you break your wrist, because wrists are very hard to fix with casts. So, because there's so many tiny bones in there. This one was $26,000, despite being years later and obviously better. Like, maybe you can't see these on camera, but like this scar goes and like looks very angry. And this scar is this tiny perfect line. This one was done at the teaching hospital. This one was done at a Catholic professional hospital. The amount that the insurance covered was 100% because I had already hit my out-of-pocket maximum of $8,500 a year. If I had not already met my... Oh, and as I was getting wheeled in, I was asking everyone if they were in network. I was very afraid of the anesthetician not being in network because that happens all the time. This one would have cost me $8,500 out, like, at a minimum, if I hadn't already hit my out-of-pocket maximum. Cheryl says, is that the same year you saved a hiker's life? You should get bonus points for that, Tomas. I do think that, like, you know, insurance should give you some sort of discount for... You brought him another patient. Can't you get a referral deal? It's the most American thing. I'm sorry. I apologize on behalf of what my country has done to me. Scott says, have you read about Phil Gaiman's insurance saga? Man with double insurance still owes nearly $150,000 in medical bills after bike crash. I am not surprised. I gotta say, I'm not surprised. No, I have not read about it, but I would like to read about it. It's like, I was just reading another one, which was like a woman who was a nurse who worked for the hospital where her child was born, thought she was going to be very savvy, ended up owing $1.1 million after insurance when her child was born. Oof. Iris says, ooh, referral deals for when I bring in my kids? Cool. This is not how we should be thinking to fix the system. I just feel like if you try to solve the problem with the same thinking that got you into the situation, you're probably not going to solve it. Tomas says, I was afraid his ambulance would get charged to me since I made the call. That is not how it works in the US, but I appreciate that fear. I'm very happy you saved that person's life, by the way. So I'm glad that you made the call. Also, you had to make the call, didn't you? Because you had a sat phone. Is that right? Or, oh yeah, you had like a beacon because there was no service out where you were. Tomas is a hero, by the way. You should go look up his name. He saved someone in a very remote part of Oregon. Dora is just melting over here. This cat cam is really something. I think that Tomas did get karma points. Cheryl says he should have gotten karma points. I think Tomas got karma points. The problem is karma points are not redeemable in the United States healthcare system. They think on a more generational level, I think. Not an expert on religion, but yet pretty familiar with the U.S. healthcare system, and it doesn't seem like bonus points get you anything. Although I think I've earned about $50 from filling in dumb surveys and linking software so that they can have more data on me at my insurance company. They'll give you, like, they have, like, a program where that's, like, a rewards program. This is, like, things that shouldn't exist in American healthcare. A rewards program where if you, like, sit through a slideshow or you answer a survey about your habits or you, like, link up your Fitbit, then you get a $10 gift card up to, like, $50 a year or something. And I've always been like, yes, I will milk any of these things. Well, thank you all for joining this. How about you tell me something good that's happening this week instead of just ranting about medical bills? Oh, should I offer some closing notes about why we're worse? Why we are worse. Profit motives are built in at every level of the system. Sickness equals profit. Sickness does not equal health. So we like to treat health because the treatment is what makes money. Health is not what makes money in the United States. And the fact that it is not a free market because you cannot be an informed consumer when it comes to healthcare, nor can you be a rational consumer when it comes to healthcare. So as much as we want the market to make rational decisions, we can't, right? Because you don't have all of the training of the doctor, nor do you have all of the rational sanity when it comes to the health of yourself or your family. And because you're desperately trying to make sure that people stay alive, right? And last but not least, how do we fix it? I don't know. First step, I would say, is be informed and advocate for yourself as a patient, because more informed patients makes more agitated and informed people to lobby for change in the United States. There are no short fixes for the United States. None whatsoever. The one thing I will say, if you are in a state that doesn't have Medicaid expansion, and there's any way that you can advocate to try to get Medicaid expansion in your state, the federal government is providing every possible carrot right now to try to get state governments on board to expand Medicaid of the 12 holdouts. So please, if you're in a state that doesn't have expanded Medicaid, just work very hard, because that makes a huge difference to access to healthcare for low-income people. John says, I get my new projection clock weather system, and I'm 1 year older this week. Happy birthday! Thank you for joining for your birthday week. Also, that is next weekend, so I should remember that. Also, Please tell us what the projection clock weather system is, because we need to order one because ours broke. Oh, I see that one has already been ordered and it arrives on Wednesday. Great. Cool. Well, I guess I don't have to make that decision. Iris says, good news. I'm visiting New York City for the first time this week. Congratulations, Iris. I'm excited for you. I don't know if I really envy a travel into New York City right now with Delta popping off, but I'm doing international travel in a couple weeks. New York is great. I know it sounds super touristy, but I still totally recommend a walk along the High Line. It is it's just cool. It's just a cool system to see, and it's like a lovely bit of urban nature in the city while also being gritty and industrial and lovely. So Iris says, no Delta, lots of masks. Okay, great, good. No Delta, all the masks. That's awesome. We ordered 10 K95s for the trip to Denmark that we're doing, so. Cheryl says, going to a conference. Not sure if I'm looking forward to the exposures. Are you going to wear a K95? That might be what I would recommend as a non-healthcare expert whatsoever. Iris says, I saw the High Line online. Thanks for the recommendation. It's totally touristy, but you're going to be a tourist your first time in New York, so you just gotta embrace it. And it's not touristy like in the tourist trap sort of way where you're going to have to wait in line for hours and be charged a ton of money. It's just like a thing that mostly tourists do, but it doesn't make it bad. Cheryl seconds High Line. You can also ride bikes on it, but I actually think it's better to walk on. I don't think it's great for a bike ride. Aaron says, the High Line isn't touristy. It's just a great way to get around. It's not really a way to get around for most New Yorkers. Iris says, I absolutely love being a tourist. That's great. Really, the basic rules of New York are avoid Times Square and, pick your neighborhood and then try to, like, focus on that neighborhood because it takes forever to get anywhere between neighborhoods. John says, thanks, lacrosse technology with all the things, including wind speeds and rain. I'm very excited how the projection works because our old one claimed that it had weather info, but the symbols that it used to indicate the weather info on the projection were very inscrutable. So Scott says, is the High Line the New York equivalent of cable cars? One, I think it's a little cooler than the cable cars, but it's a conversion of the of what was a rail line into a walking path, but it's high up and it's goes through the meatpacking district and everything, and so you can see in the back. Iris, the NYC panorama in the Queens Museum of Art. Go see it. Look for the little planes in Idlewood. John is a New York native, so you should listen to him. Iris says, it's a park planted on an old railroad, I think, but up high. Yeah, that was probably a better description of what I had. It was an elevated train, but now it's a park. It's great. It's wonderful. You can walk it or you can roll it. So I would say it's better walk. It has art exhibits and stuff on it too. It'll have outdoor installations and stuff. Iris says, I don't have any museums on the list yet. Oh, it's this week. I was going to say, if you're going during the last week, the last Tuesdays in New York, a ton of the museums are free. So that's nice. I'll tell you what my favorite museum in New York is. In Brooklyn. I've been there too many times to count, but my favorite museum in Brooklyn is the New York City Subway Museum. And I just love it. It's a live track subway museum. So it has all of the historical cars from New York City subway, and you can see cars with the original ads in them dating back to I think it has some of the 1890s cars. Anyway, it's fantastic. It's great. It's not too expensive. It's if it rains or there has some kind of inclement weather, then it is a great option because it's underground in the subway area, and it's great. It's a fantastic museum. I've been to it a lot of times, and it's right in the heart of Brooklyn, so it's very easy to get to. As you may imagine, it's easy to get to on the subway is the Subway Museum. John says you can eat your way along the number 7 line on your way to Queen's Museum. A different cuisine every stop. I think probably most lines, if you got off, you could probably do a different cuisine on every stop in New York City. But Queens would probably work. The La Crosse clock was the one I was looking at. I ended up going with a generic no-name one that was $18. I like that we're turning into a weather recommendation one. Craig says, kids start school here in person in North Texas this week. Fingers crossed. I don't know if that's a good thing or a bad thing, really, but no one does. So, hope it all goes great and that everything is safe and wonderful. I'm wishing you the best with that, Craig. Yeah, there's plenty of museums to choose from, so whatever you are into, Iris. I like how this just turned into a recommendations for Iris. And a clock weather stations channel. All right. Well, I hope that Iris enjoys the trip to New York City and all of the apparently transportation-related things that we recommended. And John has a great birthday. And then Cheryl enjoys the conference and that kids' school is extremely safe for Craig's kids. And I hope everybody has a lovely week and has 0 unwanted interactions with the U.S. healthcare system this week. And stays safe. And I will see you all here next week to talk about something to do with finance and economics and eat a donut. Same time, same place. All right. Cheers. Have a safe week. Bye.